Okay, we'll start some ligaments. And we know these from lab already, I think. Some of the pathologies we didn't really touch on too much. So, posterior longitudinal ligament. It's a nice picture of it right there. We know it also has those little side fibers that go out and kind of support the back of the disc, kind of beef it up, give it a little extra support. Because we talked about last time, there's some weaknesses in the annulus fibrosus posteriorly. Remember we said some of the lamellae were incomplete posteriorly, so it encourages disc herniation. And we said the lamellae are thinner in the posterior and posterior lateral regions. So to compensate for that, perhaps we have these little kind of side fibers that come out from posterior longitudinal ligament. Some very easy board type questions about the posterior longitudinal ligament. It's more narrow in the lumbar spine, and it gets progressively wider as you move toward the cervical spine. Exactly the opposite of the anterior longitudinal ligament, which is wider in the lumbar spine and gets more narrow as it goes to the cervical spine. That's a classic. Since I was in school, I remember that question being on there, so don't miss that one. Let's see. It covers the posterior vertebral body, more in the midline, the main part of it. We talked about those little side fibers there. It's 3 to 4 times thicker in the cervical spine compared to the thoracic spine and lumbar spine. So that's kind of strange. And those, a thin sheet of extra fibers, those are the ones we just talked about. They come out laterally to perhaps give a little extra protection to the disc in the disc herniation area. And kind of gives it, they say, a serrated appearance. I don't know if that's really true, but there they are there. This is a more realistic drawing. It's kind of hard to really see a difference between the main body and these kind of side fibers here. Of course, is this A to P or P to A view? A to P, P to A, P to A. Because we've cut the pedicles here. I think that was on a lab. Was that a lab question I think I had? Put like a number on one of these little stumps to see if you could figure out what that is. But those are the pedicles cut, and the posterior arch is removed, vertebral arch has been removed, and the caudate quine has been, everything's been removed, so you can see right up against the posterior part of the body. So very similar to the anterior longitudinal ligament. If you want to get into the weeds on histology, there's 4 different bands of fiber within the posterior longitudinal ligament. Some of the fibers connect disc to disc. Some span up disc, and disc, and some span up even 4 layers, and some even go 5 layers, which wasn't even drawn. So that's the thought, to maybe add a little strength to this ligament. This is always a good one here. Unlike the anterior longitudinal ligament, these blend in with the fibers of the intervertebral disc. The anterior longitudinal ligament doesn't sink into the disc itself. You can take it off real easily. Again, perhaps to reinforce the posterior of the disc, which is so close to the nerves that cause sciatica, it is dug right into the disc, the annulus itself. Sometimes it's hard to remove that without ripping up the disc. There is a name change, and we'll cover this again when we get to the cervical region. But posterior longitudinal ligament will be coming all the way up from about S1 or S2, comes all the way up. But when it gets to the body of C2, it changes. I mean, it changes morphology. It's really the same ligament, but it does get wider and it gets more thin. So it becomes more of a membrane compared to a ligament. And so they gave it a new name. They call it the tectoral membrane. So the tectoral membrane is what actually connects to the skull, or the foramen magnum of the skull. If you want to get more specific, the clivus of the skull, and not the posterior longitudinal ligament. So watch out for that one. The anterior longitudinal ligament does go all the way up to the occiput, so that's another easy difference between the two. Another softball board type question. PLL doesn't go all the way to the skull, but the ALL goes all the way up to the skull. Okay. And let's see, so I don't know why I have that picture there still, but down low, where does it end? As we said, it ends at S1 or S2. Sometimes it ends and doesn't reform. Sometimes it morphs into our friend, the deep dorsal sacrococcygeal ligament, which we've seen before in lab. So that is the deep dorsal sacrococcygeal ligament is considered a continuation of the posterior longitudinal ligament. Another kind of easy board type question. This is strange. So another weak spot. This will be our third weak spot that encourages disc herniation posteriorly. So the posterior longitudinal ligament has a area that isn't formed in most people. Let's take a look at it. Here's a really nice drawing of it. And you can see, here's these kind of side fibers coming out. They cover the inferior part of the posterior lateral and posterior part of the disc really nicely and protect from herniation. But there's a little window right here and right there that there's no extra protection. And this is another reason why disc herniations occur right in this paracentral zone. So that's a third weakness. So I can see the question coming. Which one of the following is not an inherent weakness of the disc to prevent disc herniation? So we said one is incomplete lamellae formation, posterior or posterolaterally. One is the lamellae are thinner, posteriorly or posterolaterally. And the third one is the side fibers don't cover the entire back of the disc. There's a gap right in the paracentral zone where there's no posterior longitudinal ligament, yet all of this is covered. So if you're going to herniate a disc, it's going to be right through this little window right here in most cases. If the herniation is big, it'll rip the posterior longitudinal ligament and it'll cover this whole area. But nevertheless, it's a weakness. And here's a real specimen where the vertebral arch has been removed and the quadricline has been removed, and you can see. It's kind of hard to see, but there's that little window right there. Okay, so 3 weaknesses. We should know these, I think, because another slide you're going to take with you for the rest of your chiropractic lives. And this works for MRI. This happens to be a CT scan, an overhead kind of bird's eye view of, we know what that is. What is that thing right there? That's a vertebral body. How about this? The facets, Z-joints. How about specifically, can anybody tell me who that is? Superior articular process. If this is L4, superior articular process of who? L5. This is L5 property. The rest of the bone is deep into the plane of the page, and you can just see this part here. All the rest of this is the same. If this is L4, this is all L4 property. Inferior articular process is right here. Thank you for getting the door. So this would be inferior articular process, superior articular process, and that's the actual facet joint itself. Now, this is kind of a weird thing. We can't see on an X-ray or on a CT, we can't see the thecal sac. How come we can see the thecal sac so nice here? It's filled up with contrast, and contrast glows white when you expose it to photons of X-ray or CT. So this is called, they've injected contrast. This is called a CT myelogram. Can you order these once you get your license? Yeah, you absolutely can. This is the ultimate. If you can't figure out what's going on with a patient, you've done MRI, you've done X-rays, maybe even a bone scan, you can't figure it out, this is the last card you pull out here, CT myelogram. Because you can notice it fills up the thecal sac, and it even fills up the nerve root sleeves. We can see the S1 nerve roots right here. If there is something pinching the nerve, the contrast won't fill and you'll get a big kind of a dark defect here. Sometimes bone spurs can't be seen well on MRI, and they'll be caught on this CT myelogram. But the point of this is to teach you these zones. When you get a radiology report back, you ordered an MRI. Maybe you're really good at reading an MRI, and hopefully you will be. You don't need the radiology report. When you're starting out, you should always read the radiology reports and try to see what the radiologist sees. It's a good teaching mechanism. But you'll hear these zones. The herniation was in the central zone, is right in the middle. Here's the paracentral zone, which is where the weakness is. Most herniations occur in this paracentral. More of a European AKA is the subarticular zone, which is not, I don't like that word because really the joints articulate really in the foramen here. So not the best terminology, but nevertheless you might see subarticular herniation. That's an AKA for a paracentral herniation, and that means a herniation right in that posterior lateral region here. Once you get in the neuroforamen, that's the little green zone here. That's called the foraminal zone. Once you're out of the little hole, the neuroforamen, those are called the extraforaminal zone or far lateral zone. So I do expect you to know these zones. So if I put this picture up and I put a big herniation right in here, you should be able to tell me what zone the herniation is within. And just here's another kind of a P to A view showing where these zones are. There's subarticular zone, central zone, foraminal zone, far lateral zone here. It's pretty simple really. But again, this is for the rest of your chiropractic lives. This slide, you will have to recall this. So let's put that to use now. So here's a 44-year-old male. Male comes in. He has left foot drop. What does that mean? Has anybody heard that word foot drop before? A couple people have. So they'll come in and they trip when they walk. I'm all tethered up here so I can't walk. But when you walk, you need to be able to cock your foot out of the way, correct? What if you can't cock your foot? You can't dorsiflex your foot. You're going to drag it and trip over it. And that's what happens. So if the nerves that go to your dorsiflexors, tibialis anterior, Tom, Dick, and Harry, basically, if the nerve that goes to those muscles is damaged by a herniation or anything else, you start dropping over your foot. So you get what's called foot drop, a very common problem with an L4 herniation. Neurological evaluation, so you check him out. He has, not surprisingly, very weak dorsiflexors. And you'd have him do a simple heel-toe walk. He can walk on his tippy toes. What muscle is that if you walk on your tippy toes? What muscle is that testing? Gastrocnemius, what nerve is that? Mainly S1 nerve. It's a quick way to screen for S1 problem. No problem, he can do that. When you have him walk on his heels, like walk on the balls of his feet, he can't do it. He can do it, but he can't get his foot out of the way. So he can't heel-toe walk. It's just another quick screening tool you can do. And what nerve is that if you can't heel walk in general? In about 85% of humans. That's L4. So if they can't heel walk, it's usually an L4 injury. If they can't toe walk, it's usually an S1 injury. What about L5? Anybody know what that one is? Extensor hallucis longus, the big toe raising muscle. Always test that on your patients. When I do my consults, I won't even talk to them if they haven't done all these tests so I can understand what's going on. If they're positive, then I turn on the camera and I make them do it in front of my own eyes. You can take a stick and push down the big toe and see how much fight it has. And a lot of times if they have an L5 problem, that thing will have no power at all. And that is extensor hallucis longus is it's pure L5 in probably 95% of the cases. So it's a very strong indication of an L5 problem if they don't have the power to raise their big toe to the ceiling. So this patient couldn't walk in his heels. Everything else was fine. So because the neurological evaluation was positive, and this has been going on for 4 months, you immediately order an MRI because of this positive neurological evaluation. And while you're waiting, you start flexion distraction treatment, which is designed, you're assuming he's got a disc herniation. Not much back pain either. It's all this foot drop thing and some sciatica. So you order your MRI. What do you think? I don't think I've showed you one like this before. So let's get our orientation here. Here's an overhead view. It's really from underneath the inferior to superior view. That's why the sides are reversed on this image. So everything left is over here, everything right is over here. And we've seen this before, right? We just saw it. There's the superior articular process, the inferior articular process, there's the Z joint. You can see the thecal sac right here. You can see some of the cauda-equina members kind of hanging out in the thecal sac. You can see some of these have already budded off the thecal sac and are out. So those would be, if this is L4, those are the L5 traversing roots here and here. These are the L4 roots right here, the exiting roots. Now we always look at someone with leg pain, when you see an MRI, you look at the back of the disc to make sure it doesn't have any big bumps sticking out the back. Anybody see a big bump sticking out somewhere? It's not in the normal place, is it? That's called that huge bump right there is a very big, that's called a far lateral herniation. Why do you call it far lateral? Because it's in this zone right here. It's in the far lateral zone. You could call it an extraforaminal, more in Europe than in our country. But yeah, they have a far lateral herniation. Do you guys know what the dorsal root ganglia is? We haven't really talked that much about it, but some of you have probably had some basic neuroscience before. That's where the cell bodies of the nerves live. Very delicate structure. Doesn't like to be messed with. You can have really, really bad pain if you get a herniation far lateral. And to make things worse, the treatment, which would be, if the chiropractic treatment fails, and if it fails to naturally reabsorb, and they don't get better, then you have to have the disc cut out by a procedure called discectomy. Discectomy works great on if you're a perfect candidate for it. Out here, it doesn't work so good because you can't access this area. You have to come in through muscle, and you use this kind of far lateral approach or transforaminal approach, and you're right on top of the dorsal root ganglia. So you have to grab the dorsal root ganglia with instruments and move it out of the way in order to get this herniation. And this thing is super sensitive, and it doesn't like to be touched. The success rates for far lateral herniations aren't nearly as good as they are for paracentral herniations. So this patient actually did pretty good with the far lateral procedure. But I always warn them, I said this, it's best if you can just heal with time. But these are also time sensitive. You don't ever want to do surgery more than about 4 or 5 months. You certainly don't want to do surgery more than a year. The chances of the nerve damage is already there. So if you take the pressure off the nerve, it's probably not going to make a whole bunch of difference. If we look at this cut, so here's L5, here's L4. This isn't a cut right through the middle like we're used to seeing. This is a far lateral cut right here. And if we look, let's look at 5. You can see a nice big hole right there. Everybody see that fine? And there's the exiting nerve root hanging out. Nobody's bothering it, but when you go up here to 4, you can see part of that herniation has touched the nerve root here. Just kind of, you always want to, when you look at MRIs, you want to double confirm. If you see a herniation, always make sure you can see it in both planes. Sometimes the MRI can play tricks on you. It can kind of draw in a herniation where there's really not a herniation, so you always want to look in both places. But nevertheless, there it is right there. So there's your first far lateral herniation. Any questions about that, or pretty straightforward, I think? Okay. And there's everything I said. All right. What does the posterior longitudinal ligament do? Well, it reinforces the posterior and posterior lateral annulus for sure, so it helps prevent disc herniation. And then, kind of mechanically speaking, it resists bending forward. So if you bend forward, this thing will get tighter and tighter and tighter, and it kind of resists you bending forward or flexing forward. Does anybody know the correct term for forward flexion? Sagittal rotation. We're going to do our biomechanical lecture where you get to learn all these things, but anterior sagittal rotation. So it resists anterior sagittal rotation or forward flexion. It also resists something called superior coronal translation. If I would stand over the person and just pull them up like a distraction treatment, that's a superior coronal translation in biomechanical speak. In kind of normal speak, clinical speak, it's distraction or axial distraction, and that'll make more sense when we do that lecture. All right, let's go to the anterior longitudinal ligament. Lumbar spine, you can see it's much broader here than the PLL was. This is the only ligament that's found in the anterior part of the vertebral bodies. This one is just the opposite of the posterior longitudinal ligament. It's wide in the lumbar spine, and then it gets more narrow as you go up. By the time you're in the cervical spine, it's pretty thin and thick. It also has 4 distinct bands. One band of fibers crosses the 1 disc level, another band crosses 2, 3, 4, etc. And they're not all in order, they're all mixed up in here. So it gives you some extra strength in this ligament. These are anchored into the, what's periosteum? Dr. Doe go over bones yet? Periosteum's the outer kind of coating around a bone. It anchors into that. It doesn't really anchor into the intervertebral disc, as we said, like the posterior longitudinal ligament does. What does it do? Well, it also resists that coronal translation, that axial upward force as well. It engages in extension because it's on the front. If you bend backwards, this is going to get tighter and tighter and tighter. So it resists extension, where the posterior longitudinal ligament will resist flexion. Okay. Clinically important. Does this have? This has a couple clinically important things we can talk about. You're going to treat hundreds and thousands of patients who've had this whiplash. You guys have heard of that before. Where you're sitting at the stoplight, some car's not paying attention, slams into the back of you. The car goes forward, your head goes backwards. Hopefully you have a headrest on your car. Your head hits the headrest and bounces off that and goes forward before you can even react to it. That can be really dangerous, especially if you don't have a headrest. Your head will go all the way back and hit until it hits something, which is usually the seat way down here. That's more serious injuries occur if you don't have a headrest on your car. But that puts a lot of force. That back and forth motion is called by lay people whiplash. And we said that the anterior longitudinal ligament resists extension, and it can even be ripped right out of the bone if you don't have a headrest or if the impact is significant. And you can get fractures called avulsion fractures from this type of injury. Same when your head comes back, the posterior longitudinal ligament can rip part of the disc because remember that's attached to the disc. The force of you going forward is reduced a little because you've kind of rebounded off the seat, off the headrest. But the force of you going back is significant and it can do some damage. If your headrest is really low, you should put it up, especially in this crazy Bay Area traffic. So here's a patient who was in a rear end motor vehicle accident. has had chronic pain since he comes into your office, and they took x-rays at the emergency department, didn't really say anything, and you take your own x-rays, and lo and behold, we haven't studied the cervical spine yet, but it's the same principle. We have vertebral body here, and the anterior longitudinal ligament would be right in the front, anchored to the bone, and we can see a chunk of bone has been ripped off right there. So that's an avulsion fracture, especially if it wasn't there in the emergency room x-rays, because sometimes it takes a while for these things to show up. They're not always present at first. There is a condition called a persistent epiphysis, which you will learn about in radiology. It's always a differential diagnosis. So maybe they're just born with this look, but I mean, you have to treat this like an avulsion fracture because of the accident they just had. Put them in a collar. I wouldn't be using grade 5 manipulation on this. Let this thing heal up. Sometimes it'll heal back together. Sometimes it'll never heal together. It'll just be floating out there forever. But it'll get better with the passage of time. So watch out for avulsion fractures. Another problem, I think we talked about this when we talked about the seronegative spondyloarthropathies, but the anterior longitudinal ligament likes to turn into bone, and it's a ligament. It's not supposed to be bone. And so there's one condition in particular that you'll run into for sure as you go through your clinical practice, and it's called diffuse idiopathic skeletal hyperostosis. Has anybody ever heard of that before? Usually no one's heard of it, and it's fairly common. It's kind of affectionately called dish, is what you call it. And it's a condition where, so here's a lateral view of the spine. The anterior longitudinal ligament, normally you don't see it on x-ray, but here we can see a flowing calcification of the anterior longitudinal ligament here. And this patient has dish. The thoracic spine, no big deal, really not that huge of a deal in the lumbar spine, although how is the range of motion going to be in these people if their ligaments are calcified? It's going to be pretty crummy. But in the cervical spine, it can present some special problems because it gets close to the larynx. And let's see a picture. Look in the cervical spine. Look at this one. See all that bone formation? So here's the black means that there's air. So trachea is here. So this is the oral pharynx right here. The larynx, there's the epiglottis right there. So the larynx would be right in this area here. And you could see how, well, you haven't seen enough of these to know, but there's not much space here. If you swallow a big piece of food, the esophagus will push right into the larynx. The esophagus, by the way, is right here. You can't really see it because it doesn't have air in it. But when you swallow food, the food is going to be pushed way out into the larynx. So you're going to have trouble swallowing. So that's called dysphagia, trouble swallowing. And then you could have trouble speaking. You could have dysphonia because of this condition. So it is clinically significant. So in the cervical region, you have something called dysphagia, which is trouble swallowing, and it can cause trouble with speaking, which is called dysphonia. I expect you to know these words. In fact, we're going to be introducing a medical terminology class if everything goes well, kind of piggybacking it on this class, and this would be these are words that I would give you anyway in that class. So no dysphagia, no dysphonia, trouble speaking. If it hurts when you swallow, it's called odynophagia. But I won't put that on. I'll just be happy if you know dysphagia mean it doesn't really hurt, but it feels uncomfortable. There's some other conditions that also can calcify the anterior longitudinal ligament. We talked about ankylosing spondylitis. Osteoarthritis usually doesn't do it more than a couple levels, but it could be. So those have to be differential diagnoses. What does that even mean? What's a differential diagnosis? Because when you work up a patient, you take a history, you do an exam, maybe take some x-rays or review an MRI, and then you have to make you have to put forth your professional opinion. That's going to be your primary diagnosis. In this case, it would be DISH, would be your professional opinion. If you're billing insurance, there's codes that go along with those diagnoses that you would have to put on your billing for DISH. But you always have to make a secondary diagnosis, like, I'm 90% sure it's DISH, but it might be this. That's a differential diagnosis. It's like a second string. Sometimes they're very hard to tell apart, the primary from the secondary diagnosis. So differential diagnoses would be ankylosing spondylitis. That's one of the seronegative spondyloarthropathies. You probably haven't started studying that stuff, but you will, because that test is coming next week, right? Could be osteoarthritis. So you could, to rule out ankylosing spondylitis, you remember that's one of the seronegative spondyloarthropathies. So you could test for HLA-B27 antibody. You could order a test for that, and you can order a test for rheumatoid factor. If the rheumatoid factor comes back negative, but HLA-B27 comes back positive, they might have AS, ankylosing spondylitis. So I know that's a lot for your brains to process right now, but that's where you're headed through this program. You have to be able to do it just like I did it. And you will be able to. All right. Just a little bit about DISH. It's also named after the guy who discovered it, this Forstier's disease. And it's a condition, loves the anterior longitudinal ligament, but the patellar ligament can sometimes turn to bone. Other ligaments can turn to bone too. It's not just the anterior longitudinal ligament. The pathophysiology, like what's the deep mechanism of why this works, we don't understand why it turns to bone in this day and age. Typically shows up people in their 50s. So another thing, like I assume you know, the 6th decade of life, it means you're in your 50s. Right? The first decade is 0 to 10. The second decade is the teenage years. So you kind of get ahead one with regard to decades. Yeah, it's found in about 19% of men to some degree. You're going to see this for sure. Why isn't it a big deal? Why have you never heard of it? A lot of times it doesn't cause any trouble. Maybe they get a little bit stiff, but that's it. They don't often go to problems swallowing and speaking. Only 4% of women have this problem, but it is very common. And we looked at that already. This patient had a lot of trouble with swallowing, and next quarter when you study the esophagus, you'll see why. This should be way open here. There's no room for the esophagus to swallow. It's usually asymptomatic. Patients get a little stiff, and as we said, you can have trouble with dysphagia. Oh, I did put it in here. If it's painful, if it like flat out hurts to swallow, it's called odinophagia. Rodinophagia, so some more vocabulary words for you. All right, let's get to ligamentum flavum. Do we want to break or do we want to go straight through? Straight through, let's go. Okay. What time is Dr. Doe quiz? Oh, at 1. Oh, you got lots of time. Lots of time. All right, we'll go through anyway here. So we've talked about ligamentum flavum in the lab before. Here's a nice view. A to P or P to A view? P to A, 1 vote for P to A. Any other votes? A to P. Because why is it A to P? What's this thing right here? Yeah, it's the body. So we must be looking, nice try though, from front to back. So this is an A to P view. Same deal though, we've cut the pedicles and we've pulled the vertebral body out of the way. We've taken out the spinal cord and the thecal sac and all this stuff so we can just see really the roof of the vertebral canal here. And here we can see a yellow type ligament. That is ligamentum flavum, and it's super clinically important. It's called the yellow ligament. It's unique to all the other ligaments because it's filled with elastic tissue. elastic fiber. Therefore, it's very stretchy and it has the ability to recoil. It's also got a weird little, where's that molecule? Where did it go? I guess I took it out, so I won't go that deep into the weeds then. But it's filled with elastin. What does it do? Well, look, you can see what it does. It hooks the adjacent, well, what you tell me, what part of the bone is this, here and here? Lamina, right? I'm not used to looking at it from the inside out, but that's the lamina. That's the roof of the vertebral canal. So it holds these lamina together. So it basically holds the back of your spine together, and it forms the roof of this vertebral canal. Okay, it's normally about 2 millimeters thick. I'm going to show you some exceptions to that rule. It's said to be a paired structure, so there's a right and left, but oftentimes they're melted together in the middle, and you can't tell the difference. So it can have some variety to it. These are found through C1 to C2, all the way down to L5 and S1. They are not found between atlas and occiput. So this is another one that doesn't go all the way up to the skull. So let's look at this from the now P to A view. Here's the last ligamentum flavum connecting the lamina together, even though this isn't called lamina, but we'll get to that when we talk about cervical. So here's the last ligamentum flavum. Same deal here. Above C1 this time, the ligament gets really, really thin and broad. It spans out. So we have to give it a new name. That's called the posterior atlanto-occipital membrane. So this is occiput. This is C1 called atlas. The kind of Greek word is atlanto for that. So it names the bones name the ligament atlanto-occipital ligament, or you should call it membrane though. And then it's posterior, meaning there's probably an anterior, and there is an anterior. Very strange ligament. A very important artery called the vertebral artery, which you've studied in Gross 1, right? It pierces this posterior atlanto-occipital membrane. Sometimes this can calcify, and you can get some pressure on the vertebral artery, which isn't a good thing, because this is one of the main pipes that supplies your noodle. This actually feeds into the circle. Have you studied the circle of Willis yet? You will, and we'll do that in 5th quarter again. That's a very important area in the brain. But we'll talk more about that when we get up there. It's said to be the roof of the vertebral canal, we said. Here's a nice overhead view, or really from bottom up. Left side would be here. There's a nice disc. There's a nucleus in the middle. And there's a nice big thecal sac. Sometimes thecal sacs are huge. Sometimes they're small. This is a pretty good size one. You can see the nerve roots. What nerve roots do you think these are right here? If we go down a few slices, these will rip right out. If we go down a few more slices, they'll look just like that. Yep, you got it. S1, good. Those are the S1 nerve roots. Kind of strange because they're usually already ripped out at L5. But nevertheless, take a wild guess what these. Here's a motor and a sensory root together. Take a guess which one those are. If that's S1, who do you think these are? S2. How about these? S3, S4, S5. CX1 is in there somewhere. So they often line up like that really nicely. Where's ligamentum flavum? This is pretty much a normal one. See the black region right here? Actually, I could do my drawing tools here. Let's draw them in here. There's ligamentum flavum. This one actually is a type 3, it looks like. So, not a big deal. I have some patients I talk to, it looks like this. Is that a good thing? No, it smashes the thecal sac into a little ball right here, and they have claudication. They can't walk. We'll look at the mechanism behind that in a second. So, But there it is. Okay, going into the weeds a little bit. The upper, the superior part is attached to the anterior surface of the lamina. The lower part is attached to the posterior surface of the lamina. So it would look like this from a P to A view. You can actually see ligamentum flavum kind of hanging out here, but then it disappears. I just kind of photoshopped it in here. This is where it would be, but normally you wouldn't see this. This is on the inside or deep to the lamina here. So that's kind of weird. So it connects to the anterior part of the lamina here, and here it connects to the posterior part of the lamina. Kind of a strange setup. What about the histology of this? Oh yeah, I did. This is where I put it. Well, we said it's elastin mainly. It's 80% elastin, which is very strong. Mainly type 1 collagen, about 20% type 1 collagen. But it's got this really strange elastic-like molecule called alunin. And this one has the ability to recoil like crazy. So that's mixed in with this. And so therefore it really has the ability to recoil. It's also unique because it's yellow, because of that high elastin content. It's always hard to see in cadavers. This is pedicle, has been cut here. Pedicles are cut here and here. So this is a kind of a to P view, but we have a little obliqueness. It's not a perfect A to P view. It's a little bit of a side angle. And you can see it right here. So all this yellow, that's the yellow ligament. That's a real fresh ligamentum flavum. All right, what does it do? Well, because it has the ability to recoil, technically, if you bend forward, and it's on the posterior part of the motion segment, if you bend forward, it stretches, and when you start to bend back, it contracts, so it technically helps a little bit with lumbar extension. So probably less than 1%, I would say, but technically it does. In discectomy, they remove it. Bogue Duke goes on a rant about, there's a bunch of people saying, oh, if you take ligamentum flavum out, you're going to have all horrible problems. There's never been a proven disability from the absence of ligamentum flavum. Kramer, I know this is a board book. He's not a very good, in my opinion, clinician. There's some really gross mistakes with the book. I think this is one of them, but it could show up on board, so I better tell you about it. Kramer says, quote, the most important function of ligamentum flavum is to prevent buckling of ligamentum flavum during extension. So if you extend, you want ligamentum flavum to pull out of the way so it doesn't poke out and pinch the thecal sac, and which could theoretically cause irritation and such like that. I've been doing this a long time, since 2003 I've been consulting. I've never seen a case of this. The problem is always that ligamentum flavum gets too big. It's not a buckling phenomenon. It just grows. It's almost like, who's heard of prostate? Guys have trouble with prostates when they get old. A big number. You get over 70, probably 80% of guys have trouble with urination because the prostate gets big. Ligamentum flavum is similar. We don't know why, but it just tends to get bigger, more in guys than in girls for whatever reason. But it can cause trouble, as we'll see in a case here in a second. And it's this hypertrophy, because it's against the thecal sac, it can crush the thecal sac, and I shouldn't say more importantly, but it can also crush a bunch of blood vessels that live back there called the epidural venous plexus. When you work out, when you go for a run or you do some squats, you're working your muscles, correct? Are you working your nerves? You're absolutely working your nerves as well. Your nerves are generating more waste and acid. They need more oxygen, just like a muscle does. Well, there's a very important set of veins that surround the vertebral canal. It's called the epidural venous plexus. And when you work out, and you can see that they go right down, and there's lots of little branches that go to all your nerves that aren't drawn here. But if you crush these veins severely and they don't work very good, and you go work out, what's going to happen to your nerves? Waste and acid is going to build up in your nerves, and they're going to stop working. And that's what these patients with central stenosis, their legs literally stop working after they walk a certain distance, depending on how crushed this blood supply is here. So let's see. I'll get off my slides here. So ligamentum hypertrophy, we don't know why it happens, but it can crush, well, it crushes the nerves, that's bad enough, but it can crush that epidural venous plexus where you can't get nutrients and waste, you can't get nutrients to the nerves, and you can't get waste out of the nerves. And when ligamentum flavum gets big, there's a word for that. It's called central spinal stenosis. Spinal stenosis for short, but you shouldn't say that because there's a lateral stenosis and there's a central stenosis. Classic symptoms, guaranteed you're going to have people. I guarantee these people will have told their primary doc, their family doc, and he or she will have no clue, and they'll completely miss the diagnosis. They'll come into you and you'll go, oh, I know exactly what you have. Let's get an MRI just to confirm it. They'll come in and they say, I used to be able to walk a couple miles with my wife in the morning, and then last year it was down to a mile, and now I can walk 4 blocks, and it feels like I'm walking in cement after about 4 blocks. My legs don't work anymore. Sometimes they have leg pain. Sometimes they have back pain. Sometimes they don't. Sometimes they tell me, it feels like I hear this over and over. I feel like I'm walking in cement, or I'm walking in the water. My legs just don't have any power. But the strangest thing happens. If I sit down, some of them even bring a little chair with them. If I pop out my chair, or if I sit on a bench, and if I bend forward, and I wait about 5 minutes, my legs are back to normal. I can walk another 4 blocks. That's classic squeezing of the thecal sac and that epidural venous plexus. Right, so watch out for that. The official word for it, that what I just described, where your legs stop working basically after a certain distance, it's called NIC, neurogenic intermittent claudication. Neurogenic intermittent claudication. Neurogenic means it's a nerve problem. It's a compression of the thecal sac and its nerves. I mean, really, technically, it's a vascular problem as well. But nevertheless, neurogenic intermittent claudication, they have NIC. You have to be careful because another common problem with humans is something called PAD, peripheral arterial disease, where the abdominal aorta, have you guys seen that yet in lab? You probably have, no? The abdominal, you'll see it next quarter for sure. The abdominal aorta can get filled up with atherosclerotic plaque and gunk, and it can go from 100% flow down to 5% flow. Same thing, those people go for a walk and they also run out of power. The difference between those people are called VIC, vascular intermittent claudication. So you have to put on your thinking hat to figure out if is it NIC or is it VIC that's causing this claudication problem. The difference is a huge difference. Someone with vascular problems, they can just stop walking and stand still. They don't have to sit down and their legs recharge and they can go further. If the person with NIC does that, it won't work. They have to sit down and bend forward to get relief. So that's the way to tell the difference between those. All right, so here's a side view of that epidural venous plexus here, which is important. Normally the whole of the vertebral canal should be 20 millimeters. We'll see a case here where it's about 8 millimeters. So you can see by ordering an MRI, you can tell whether they have this stenosis or not. And then we looked at this epidural venous plexus. There's an anterior, posterior epidural venous plexus. Okay, what else can contribute to this central spinal stenosis? besides ligamentum flavum thickening, they usually have a bulging of the disc. Not usually a herniation, but the entire back of the disc has gotten so weak that it bulges way out and encroaches the thecal sac. And then they typically have a spondylolisthesis, a degenerative spondylolisthesis, where the bone has slipped forward, which further narrows the vertebral canal. It's usually this triad, but you can only two of these you need really to have people have nick. Here's a cadaver section. Someone with gigantic ligamentum flavums right there. That's all ligamentum flavum hypertrophy. I mean, normally this should be, if I get my drawing tools out, normally this looks like a type 2 ligamentum flavum. It should be like about this big. And you can see it's got crazy thick here. Someone who had central stenosis. And the Z joints, how do they look? See how lumpy bumpy they are? It's like, that's called rat-bitten erosion. It's like a little rat got in there and was gnawing away at it. Very highly associated with pain when they have this phenomenon. So those are facet joint, and the facets are huge, aren't they? I don't know if you've seen enough of them to be able to tell, but those things are huge from osteoarthritis. So this,
the thecal sac is just squeezed in that little gap.
the thecal sac is taken out. There's no thecal sac.
If it was there, it would
But it'd be here, yeah, it would be pinched. It'd be smashed down because this shouldn't be here. And that's the surgery for this is a decompression where they take all this out and then they shave the superior articular process out, called the foraminotomy, and they make more wiggle room for the nerves. And it's probably one of the most effective surgeries. Again, you have to be a perfect patient for that. If you're not a perfect patient and they do surgery, it's going to be a disaster. I talk to people who are suicidal. I have to send them to the hospital sometimes because they don't want to live anymore. They had a failed fusion. Let's do a case. 60-year-old complains of pain and bilateral lower extremities. That's always kind of weird. Legs are heavy, feel weak after a walk for more than 4 blocks. So that's our nick, that's claudication. We're not sure if it's vascular yet or neurogenic. Strangely, they take a folding chair with them, sit down for about 5 minutes. Usually they bend forward as well, and they're ready to go another 4 blocks. And they repeat that until they walk their, whatever their target distance was. Radiographs, can you see stenosis on just run-of-the-mill x-rays? Nope. Got to order a CT or an MRI. MRI is fine because it doesn't have radiation. CT has radiation. Radiographs weren't really that exciting. They showed some degenerative disc disease, some degenerative joint disease. Neurological examination was normal. Kemp's test was very painful. Bending backwards seemed to create pain. So if you bent this person backwards, which jams these joints together, how do you think they'd feel? They would hurt, right? Any type of extension. The famous McKinsey exercises. Some people that hurts them so bad. If their facets are involved, you should not do McKinsey exercises. Or if you have a spondylo, if you have a fracture in the pars, you shouldn't do McKinsey exercises. Okay. So yeah, positive Kemp's test. And interestingly, they say, and I hear this all the time, they like to go to Costco with their significant other and they bend forward on the cart. Sometimes they just put their hands on it and flex forward, and they can walk forever like that. And they just follow their significant other. It feels great. So that's even got a word that's called shopping cart sign. So they had a positive shopping cart sign as well. So you order an MRI. So is this normal or not normal, this one? See how your MRI skills are developing. This is a normal one I put in just because you're still kind of new at looking at MRIs. Here's the thecal sac. They have a really big thecal sac. You can see the nerve roots, right? And we can even see what level it is. What bone is this right here? That's 5, great. 4, 3, there's a cut line. Whatever that line cuts through, it gives you a view as if this was a stick of salami and you sliced this person up into 50 slices, grabbed this, pulled it out, and threw it on the bread. This is the overhead view you get right here. And you can see a young person, there's a nucleus pulposus, you can see the annulus fibrosus, the thecal sac, you can see the dorsal root ganglia, or just called the exiting nerve root here. That would be, if this is L3, that's the L3 exiting root, or L3 dorsal root ganglia. You can see that these ones are getting ready to bud out of the thecal sac. They always move up to this 2 o'clock and 10 o'clock position. Those would be the L4 traversing nerve roots. Okay, but this is great. We said the leg pain, we want to make sure that the thecal sac is happy. Here's ligamentum flavum. Okay, it's not crazy big. Now you want to see this patient's MRI. This is what I see all the time, a couple times a month. Look at this mess. So, let me get my tools out here. This is ligamentum flavum. Does that look good? No. This is the thecal sac. Can you even see the nerves in there? You can't even see the nerves in there. That's severe compression. Compare this thecal sac to that thecal sac. It's like ridiculous. And so the epidural venous plexus is crushed, the nerves are irritated. So this is classic central stenosis. If we look at the side view here, you should have, get my tools back out. You should have at least this much room in this parasagittal view. I kind of cut it off, but you can see there's a lot of room here. Look how much room there is here. And same thing here. This is ligamentum flavum, which we normally don't see. Same thing at that level. So this is run-of-the-mill central stenosis, which you'll run into time and time again. Anybody else see anything else wrong with this? They got other problems as well. Well, always look at the alignment of these bones. There's S1. Look at L5. It's the reverse of a spondylo. It's a retrolesthesis, where the bone has slid backwards. Good try, though. Now, what about this? So this one is slid forward. So technically, that's a spondylolesthesis, even though it may be an illusion because this bone is slid back. But you would still call it a spondylolesthesis because this one is slid forward. These guys are normal here. Anybody catch this? That's a big disc extrusion on top of all this other stuff. So this patient had all kinds of problems. But the main problem was they couldn't walk, and so they ended up having a decompression. I don't know how they did. They never got back to me, but I'm assuming they probably did pretty good. If it doesn't go good, I always hear about it for sure. And when it goes good, I usually don't hear much about it. All right. Let's see, how are we doing on time? Whoops. What did I do? I don't know if I messed up the recording or not, or the safety recording anyway. Here's a nice cadaver view of severe ligamentum flavum thickening on a very fresh cadaver. Wasn't embalmed or anything. You can see this disc is also shredded, a massive annular tear through it there. Same thing here, ligamentum flavum is huge. Let's see, we're about ready to stop, I think. Should we stop here? Your brain's had it? All right, let's stop it right here. You can go study for your Dr. Doe quiz number 27. All right, email me questions if you have questions. You're welcome. All right, we're almost done with ligamentum flavum, so I'm going to just throw this in to finish off ligamentum flavum. We kind of stopped in a weird spot. So other ligamentum flavum functions. Well, they help hold the capsule of the zygapophyseal joint away from the inside of the joint. So kind of hard to get a picture of this, but here's the capsule drawn around L5S1 facet joint, or Z joint, whatever you want to call it. Sometimes this capsule can get snagged and get pinched inside the between the facet, between the superior articular processes here, and that can cause really bad low back pain. That's the kind of pain that locks you in one position. So ligamentum flavum, or this phenomenon, usually happens at the anterior part of the facet joint capsule. Ligamentum flavum covers the anterior part of the facet joint capsule, and because of its elasticity, it kind of keeps the capsule from getting sucked inside the facet joint and getting trapped. So that's another function of it. Let's do another case here. So this is a 58-year-old male, comes in, has inability to walk for more than 3 blocks, so he's got claudication, legs lose power. Says if he goes to Costco and bends over a shopping cart, feels much better. Tried 4 weeks of flexion distraction treatment. For the patient, you order an MRI. What do you think? Same type of story. Ligamentum flavum is huge. This patient actually had surgery once before because this ligamentum flavum is gone. Right? You can see this one. Let me see if I can still draw. Yes, I can. You can see this ligamentum flavum is huge. Right? And then this one is gone. So he's had some type of fusion before. The point of this image, though, is to show you that the whole posterior arch, there's the spinous process. I'll just draw the arch here. So if this is 4, this is all L4 property. This is L5 property. That's the superior articular process. You see what's happened here? Yeah, these should be in line. This whole thing should be back here. Right? This one looks like it's pretty good shape. So this has slid forward. All right? So this is called the degenerative spondylolisthesis because they were born with a facet that was, the joint is too sagittal. And because of maybe an older surgery where ligamentum flavum was removed, they probably took some of the capsule, the facet joint capsule off as well. It slid forward. So this is a run-of-the-mill degenerative spondylolisthesis. But nevertheless, look at the thecal sac is smashed. So this patient's going to need probably fusion at this time. You have to get a flexion extension study to see if this is slipping back and forth. And yeah, the other side is also compressed. The traversing nerve root here of L5 is compressed by this crazy ligamentum flavum. This facet is severely degenerated as well. So you need a decompression. This is probably unstable, so they're probably going to need interbody fusion in this case. There are 3 different types of ligamentum flavum. Get my drawing tools back out. So type 1, type 2, type 3. Type 1 would extend to about here. That's a type 1. I don't see that in clinical practice much. Type 2 would extend right about the midway point of the facet joint. I see this one. And type 3, let's make it blue. Type 3 would extend like this one is all the way over, completely crossing the facet joint. Right, so those are the 3 types. This one I don't see, this type 1, very much. Right, it's kind of a difficult type question, but nevertheless, good to know. All right, so I'm going to cut it off right there. We'll pick up with interspinous ligaments the next time. See y'all later.